The treatment for type 2 diabetes using Januvia or using SGLT2 inhibitors is really focused on keeping patients with type 2 diabetes where they should be with good glycemic control. And we know that the important thing to consider as we choose therapies is if we can get patients to target A1C levels, getting them to levels below 7%, we can really make a difference in terms of the risk of microvascular complications. The data from trials that have been done many years ago, the DCCT and UKPDS, really taught us a lesson that good glycemic control can reduce the microvascular complications. Now, these trials don't look at that. We don't have enough patients nor long enough treatment to be able to really understand whether or provide proof that these drugs can change microvascular complications. But we know that the goals we set for managing patients with type 2 diabetes are intended to improve glycemic control with the intent to prevent microvascular complications. And so the critical thing is to give physicians tools that they need to keep patients under good control. Now, would we like to see patients who develop type 2 diabetes go back to having non-diabetes? That's an important goal, and we'd love to be able to have therapies that can do that. Certainly patients who have dramatic improvements in their weight, for example, can lower their A1C back to normal range levels. But our primary goal is when patients get diabetes to really give physicians the tools they need to get glycemic control, and by having improvements in glycemic control, hitting those targets, giving physicians the ability to help their patients prevent diabetic complications. And whether they do that through erdagliflozin, Januvia, and there are many other therapies physicians can use, but the key is getting your patient to glycemic goals so that we can help them to avoid complications. It's more about different ways of reaching the goals. I think we share the vision that we want our patients to improve their glycemic control. We want to give physicians more and more tools to help them get their patients to these glycemic goals. For the reason I mentioned before, these goals are important in helping patients to avoid longer-term problems with diabetes. And so there are many new classes of drugs over the past years that have become available, and it's allowed us to tailor therapy, to individualize therapy, so that when you're seeing a patient who has diabetes, it's no longer a one-size-fits-all. It gives physicians an opportunity to really think about their individual patient. What are the issues that patient is facing? What is the profile that patient has? And the fact that we have more and more classes allows that physician to really think, what do I want to achieve? What do I want to avoid? What does that patient's goals in? What are my goals for that patient? And then tailor the therapy to that profile. And these different choices, metformin, the DPP4s like Januvia, SGLT2 inhibitors like erdagliflozin, the new insulins, GLP-1 agents, all of these offer us tools that can help us hit that important goal of getting patients under good glycemic control and helping them, we hope, to avoid complications in diabetes. Well, we're going to continue to push forward on our erdagliflozin program, so we're hoping to file in the U.S. at the end of this year. So and with global filings after that. We're continuing to work on Januvia, and we'll have additional data we hope to share on Januvia. The results from TICOS continue to give us more information about the safety profile of Januvia, and we'll have, I'm sure, more data to share at next year's ADA. We have other projects that we're working on which we'll certainly look forward to sharing from our earlier pipeline. So we'll hope to again bring a range of exciting data to next year's San Diego. I think at least the near-term future, and I'll say over the next 10 years, is of course to continue to do research to find new classes of agents to offer even more tools, because we still know that despite the many new classes, in many regions as many as half of patients aren't at those important glycemic goals that I was talking about. So new tools, and there are interesting new early pipeline assets that we have and other companies are working on as well. But I think the other piece is that there have been a lot of new classes that have been introduced. and a lot of really interesting and exciting data that's emerging about the effects that for example, SGLT2 inhibitors like empagliflozin, the trial that they've presented, suggesting improvement in cardiovascular outcomes. That type of data needs to be looked at further with other studies that are ongoing. Can we reproduce that data? Can we show that that's something that we can see consistently? Results from GLP-1 agents, some of which will be presented at this meeting as well, very exciting. But it raises the question, how do we use all these agents? When and what sequence and what combinations? I was talking about the nice data we have on the combination of Januvia and ertugrofloxacin, but where do we use that? In what sequence and what combinations and in which patients? So I think we do need more tools, and we're working on that. But I think the other issue over the next 10 years is helping us figure out what's the right sequences and combinations and in which patients. And that's going to be, I think, critical data and critical assessments over the next decade. And that's going to be very exciting to see.